Respected panel of experts and dear audience, Assalamu alaikum and good afternoon. I am Dr. Lieutenant Colonel Shaila Sharmin. I am working at Combined Military Hospital as a classified specialist there in the Department of Radiation Oncology. So this is our central experience on hypofractionated radiotherapy in post-operative breast cancer patients. The screen flash on the main contents here. It's actually an prospective observational study, single center based, and we have started our journey. CMH Cancer Center is 2028 May, and we have collected data since June 2018 up to, here it is shown up to June 2021. So it's almost 3 years data, but it's the ongoing study. It will continue up to 2028 to meet up our primary and secondary endpoints. We have taken permission as required from our ethical committee, and our data sample is 273 cases. So hypofractionated radiotherapy is an evolving treatment option, approaching widespread acceptance due to clinical benefit as well as practical advantages. Our primary endpoint is locoregional failure and to check acute and late toxicities, and secondary endpoint is locoregional failure-free survival as well as overall survival. Now, why hypofractionated radiotherapy? Actually, more convenient for the patient, equivalent locoregional control and survival rate compared to conventional fractionation is almost same, and reduce healthcare burden. And most important one is the radiobiological advantages of low alpha beta ratio for the breast tissue is 4 gray. Now, next few slides, I would like to share some clinical trials related to my study. Here is the review article published in Radiation Oncology Journal, Journey to Hypofractionated Radiation for Breast Cancer, critical review for recent updates. This study shows in a single table, there are 11 study. Most important one is the START trial. This is the pivot trial, started since 1986 and continued up to 1998. That is 12-year study, and it about 1,400 cases. They have compared the conventional fractionation with different fraction hypofractionated size, that is the 39 gray in 13 fraction as well as 42.9 gray in 13 fraction. And on this pivot trial, the START A, START B and Canadian trial have launched, and we in our center, we used mostly in this study the START B protocol. And there is a paradigm shift from 2017, that is the fast forward. This is not my part, so I'm passing this. This is at a glance the fractionation schedule. Here is the clinical trials, actually the primary endpoint. They have shown that ipsilateral breast cancer recurrence rate in case of START B is only 3.8%. And at fast forward, we are seeing that it's only 1.4. Now RTOG 1005, here it is showing that 40.05 gray in 15 fraction with SIB to 48 gray. Our next session will start this study in our center. And the others consensus guideline related to hypofractionated radiotherapy here, that ASTRO has endorsed hypofractionated radiotherapy in whole breast irradiation regardless of age, stage and administration of chemo. And ASTRO also incorporated with whole breast radiotherapy with chest wall regardless of reconstruction. So these were our inclusion criteria. We taken patient of 30 years or more, and others are as well as start B trial. These are the exclusion criteria. Now method. After having proper data sampled and the cases selection done for adjuvant radiotherapy, we do pre-simulation patient assessment and review first, thereafter CT simulation. During CT simulation, we use usually braced board and 3 to 5 mm CT slice taken. Here are the as well target volume delineation. You are seeing the free breath and breath hold technique CT slice of axial CT slice. Here it is saying that heart border is much more distant from the chest wall in case of breath hold side, and this is the free breath, and heart is so near to chest wall. And this is another slide of target volume delineation. This is the common dose prescription, but in our center, mostly we use 40.05 gray in 15 fraction, followed by boost as well 10 gray in 4 to 5 fraction. Here the IMRT plan. Now for plan evaluation, it's a utmost important thing to cover and check the all CTV coverage and PTV coverage. Here is the DVH, and DVH shows the full coverage almost of the 95% volume of the tumor, and we as well check Dmax in CTV coverage. This is another slide for plan evaluation to check hotspot and cold spot dose follow-up outside the PTV and B management as well, and final plan approval. This is another slide for where dose constraint for hypofractionated RT. Thereafter, after approval of plan by oncologist, in our center, we do practice every plan for patient-specific QA. And thereafter, we send to console for treatment. Here we do KV-KV image verification for setup uncertainty, and thereafter treatment delivery done. We do practice the weekly single OPD visit of every patient during ongoing treatment. Now the most important one is result part. Here is the laterality of breast. Here we have total data actually up to January 2025. We have found within 2021 that only 2019 year we have got left-sided breast cancers more, and thereafter it's almost equal. This is the molecular type analysis. Here HER2 positive, HR positive, HER2 negative cases are the most one. These are the tumor grade slide. Here shown that out of 273 cases, we have got 114 tumor grade 1 type, as well as 81 for grade 2 and 68 for grade 3. This slide shows which patient got NSCT. Out of 163 of total mastectomy case, 78 patient received NSCT, and in case of BCS cases, 27 out of 110 patient received neoadjuvant chemo, especially the TNBC and some cases of triple positive case. This curve shows the total data. Here 163 case for mastectomy and 101 for BCS case. And the important thing is our center established in 2018. Initially we started with 3D plan more. Thereafter gradually it increased, and then IMRT plan we do maximum. This is the pathological T stage. We have seen that in our study, T1C and T2 cases are more. This is the IMRT and 3D CRT slide. You are seeing that in 2019, we have did IMRT cases more, and thereafter almost equal. And in 2021, it's IMRT cases more. And our study is still ongoing. Here you are seeing that to 421 cases up to January 2015. We have done IMRT cases, and we have started TIBH cases since 2020, and it's almost 115 total up to January 2025. But in my study, it's a few cases, so I didn't detail more. These are the skin toxicity profile. In case of breast conserving surgery, actually we have got more cases of skin toxicity, especially those with pendulous breast or in the breast fold region actually. And somewhere the tube, drain tube, we got some acute toxicity, grade 1 type more. Out of 173 cases, we got 16 cases of lymph edema, and mastectomy, in case of mastectomy, 12 cases, so it's more. Finally, the interpretation, apart from the skin toxicity and lymph edema, patient reported for dysphagia and few cases with shoulder stiffness. Now limitations. See, our limitation is, it is the single center based study. No subgroup analysis was done, and irregular follow-up of the patient after completion of radiotherapy is really a challenge. So finally, take-home message: to achieve radiobiological advantages of hypofractionated radiotherapy, I do recommend every center, they are doing the advanced technology, they should have a comprehensive training of manpower, especially the oncology team, and the motion management system with RGS and DIB should have. Cardiac sparing planning should execute, and straightened quality assurance and daily image guidance is at most required. So these are the references. Now you'll enjoy a short video of our center, only 1.5 minutes. It's from simulation to treatment delivery part. This is our, you are seeing this is our PET-CT simulator room with breastboard. We have taken permission from, written permission from patient for this video showing. She is our left-sided breast cancer case. We did DIBH in 3 sessions, after completion of 3 session practice. This is the final simulation. This is the contrast channel. We do, yes, at first pre-contrast image has been taken. Thereafter contrast image. After having contrast image, image sent to our TPH system. Thereafter completion of, is it playing or not? Just hold it. It's running, okay. So this is the contrast slide during simulation. After this, as usually, we send for the image sent to TPS system, and image registration as well as electronic prescription, followed by contouring, planning, and plan approval. There are treatment console. Here it is showing that KV image matching for setup uncertainty with DRR. After all these things, then we start treatment. This is a DIBH plan. And this is image matching. Here is the web, yes. Yes, this is this yellow line showing that patient is in breath hold condition, and the treatment started, again is stop, again start, and thus we do practice for patient betterment of cardiac less dose. Okay, this is the last slide, I think. And thank you. This is our CMH oncology team. Here you are showing our Armed Forces Day image with the medical oncology and radiation oncology team side by side. And I would like to acknowledge our radiation oncology team giving support in every aspect for preparation and everywhere. Thank you so much. Thank you for patient sharing. Assalamu alaikum.